Thank you everyone for joining us today for this episode of NeuroNexus. Today we have Dr. Matthew J. Shepard joining us. Thank you, Dr. Shepard.
Yeah, thank you, Ashley. It's a pleasure to be here.
All right, and then we also have Natalie Brewer, the product director in the marketing department at GT Medical Technologies, who will be joining us and facilitating a discussion at the end of Dr. Shepard's presentation.
Thanks, Ashley. Excited to be here.
All right, I'll hand it over to you, Dr. Shepard.
All right. Ashley, Natalie, thank you for being here, and thanks for everyone in the audience who is viewing this. Today I was asked to go through and review a recent publication that our group had the pleasure of publishing in the Journal of Neuro-Oncology, examining the local control and leptomeningeal disease rates after resection of newly diagnosed brain metastases who are treated with GammaTile brachytherapy. And these are results from the ongoing Prospective STaRT Registry. By way of introduction, this is right here, this picture here shows how we currently think about the standard of care for patients undergoing resection of large symptomatic brain metastases. You have a patient come in with neurologic symptoms, they have a large tumor, you take them to surgery, you do a good job, you let the patients recover, and you, during that time frame, usually within 3 to 4 weeks, you attempt to get these patients back to your radiation oncology partners to treat these folks with adjuvant postoperative stereotactic radiosurgery. And this approach has been vetted and validated for quite a long time. And in fact, MD Anderson Cancer Center published this paper over a decade ago examining the impact of postoperative radiosurgery for resection cavities for metastatic disease. And what the group there found was that folks who were treated with adjuvant radiosurgery had superior local control rates 1 year postoperatively compared to the counterparts who were randomized to observation. What is important to remember with this paper, however, was that even in this randomized control trial data, where every single patient in the surgical cohort received adjuvant radiosurgery, there was still issues with local failures, especially in larger tumors that were greater than 2.5 centimeters, as shown here. This blue line were for smaller tumors. These Kaplan-Meier curve lines here were for larger tumors. And this is oftentimes the type of tumor that we're actually attempting to remove and resect when patients come in with large tumors. And furthermore, what I often tell our team here is, postoperative radiosurgery is a great standard of care, but not if you don't receive it. And so Ted Schwartz and his group from Cornell, New York at the time, found that up to a third of patients never come back to receive timely adjuvant postoperative radiosurgery following resection of a large symptomatic brain metastasis. And in fact, what their data would suggest, as shown here in this Kaplan-Meier curve, is that for patients who have significant treatment delays in postoperative radiosurgery for beyond 8 weeks, it is as if these folks have never received postoperative adjuvant radiosurgery ever at all. And this is borne out, and I think many neurosurgeons and radiation oncologists and medical oncologists see this quite frequently. Consider this patient who I treated over 5 years ago. This was a 65-year-old woman who came into the hospital in extremis. She had a large new symptomatic right frontal brain metastasis in the setting of a non-small cell lung cancer. Took her to surgery, removed the tumor completely. But for reasons that were outside of our own institution's control, namely insurance issues, prolonged rehabilitation stay, the patient never followed up for radiosurgery. And in fact, her next touch base point in her healthcare journey was when she re-presented at the hospital with other medical issues 4 months after surgery. And at that time, you can see that there was a quite sizable local recurrence in the surgical cavity. And this case is borne out quite frequently. And admittedly so, there's been an emphasis more recently in the neurosurgical literature to examine the impact of frailty, age, and other medical morbidities in the recovery process for patients with metastatic brain disease. And in fact, our own group has published on this previously. This data shown here in this slide reflects composite data from almost 10,000 patients treated over a 10-year population in Pittsburgh and the greater Pittsburgh region. And this is data from the Highmark claims database. And so we have access to a large number of folks and just figure out what exactly happens to individuals over time following radiosurgery, both in the upfront setting as well as the adjuvant postoperative setting. And what this data shows is that folks who are frail or severely frail, in addition, independent of age, have not only decreased overall survivorship following radiosurgery for metastatic disease when it spreads to the brain, but these folks are much more likely to have much higher healthcare utilization. What that translates to is that these folks are much more likely within 90 days, 180 days, and 1 year after radiosurgery to presenting to the emergency department, oftentimes for non-cancer related diagnoses, CHF exacerbation, diabetes, poor control, COPD exacerbations, and then these folks are much more likely to be readmitted to the hospital and much more likely to end up being discharged to a nursing home or rehab center. Why that's important for neurosurgeons and radiation oncologists to understand is that if you're readmitted to the hospital, you're much less likely to go on to receive postoperative radiosurgery, and you're much less likely to get on to receive adjuvant systemic treatment, which is what most of these folks really need after their CNS disease has been well controlled. And what we can see here is that, interestingly enough, at least in our practice, we found that early introduction of supportive care services for patients with metastatic disease to the brain have actually helped mitigate this to some extent, suggesting that a multidisciplinary treatment approach is imperative for optimal patient outcome. But yet, despite this, there still remains a large therapeutic gap for many patients, especially for patients traveling far distances from the hospital or have other socioeconomic factors that may limit their ability to reliably follow up. And this is what we call the therapeutic gap. And that is the discrepancy between the ideal time for postoperative radiosurgery for metastatic disease and when patients actually receive it. And in order to bridge this divide, we really do need immediate adjuvant radiation therapy delivered at the time of surgical resection of large symptomatic brain metastases. And what is that? Well, that really is brachytherapy. And brachytherapy has been employed in many disease sites throughout the human body for a long time. Until recently, it hasn't really gained much traction within the central nervous system or the brain. But over the last 100 years, different variations of brachytherapy have been employed, and for a variety of reasons, including maybe perhaps the wrong radioisotope, radiation iodine-125, iodine seeds, glioside or cesium-131 strands, there have been issues with rapid delivery of the brachytherapy and also concerns about radiation toxicity until now. And here in 2026, we now have superior technology to allow rapid delivery of brachytherapy within the brain safely, and this is what GammaTile is, or tile-based radiation therapy. Really, the innovative breakthrough with this technology is several-fold. Number one, the radiation isotope is cesium-131. Cesium-131 has a very rapid half-life, meaning that in the half-life of cesium-131 is 9.7 days, such that within 2 months of tile implantation, patients have effectively received the vast majority of the clinically effective dose of radiation therapy. The radiation seeds are also embedded in a collagen tile, as shown in this schematic here. And what is nice about this is that the seed is not only fixed in uniform spacing within these tiles, such that you allow for uniform postoperative dosimetry, but there is a built-in 3 millimeter offset between the seed and the corrugated surface or bumpy surface of the tile, which surgeons place adjacent to the surgical resection cavity. So there's a built-in radiation fall-off in this technology. So how does this look for patients after brain metastasis surgery? There's been a nice study several years ago published in Brachytherapy, which compared real use cases of tile-based radiation therapy following tumor resection. And then these dosimetry plans for GammaTile shown here were compared to theoretical dosimetry plans for CyberKnife, Gamma Knife, and proton therapy. The main take-home from this is that here, this gray bar right here is the bioequivalent dose of patients receiving tile-based radiation therapy at the surface of the cavity, where you have the highest likelihood of having active malignant cells after brain metastasis resection. And what we can see here is that tile-based radiation treatment with cesium-131 has a superior upfront bioequivalent dose, but by the time you are down at 5 millimeters, there's a rapid fall off such that the volume of normal healthy brain tissue receiving any toxic amounts of radiation therapy is much lower with tile-based radiation therapy, as demonstrated here with the V24, which is the volume of normal healthy brain tissue receiving 24 gray or higher, which has been previously been associated as a risk factor for radiation necrosis development. So we're able to achieve high doses of radiation therapy where it matters, but spare the brain tissue from radiation therapy where you don't want it. How does this work for patients with newly diagnosed brain metastasis? The Westchester group has previously published on this in a preliminary study on the STaRT Registry. This was published several years ago in Neuro-Oncology Advances. And in this early experience with tile-based radiation therapy for newly diagnosed large symptomatic brain metastasis, the authors published on 28 patients with 30 new diagnosed brain metastasis. And over a modest follow-up of 3.4 months, the authors found that there was really no increased rates of local toxicity as a result of this treatment. But we still, until recently, were needing longer-term clinical data, especially in terms of local control and leptomeningeal disease. So our group queried the surgically targeted radiation therapy registry, or the STaRT database. This is a prospective, multi-center observational study of real-world use cases of tile-based radiation therapy. And in all of these patients, the centers who are part of this registry, including our own, submit prospective data not only on local control, survivorship data, but also on adverse events and quality of life information. So myself and other authors shown here pulled our data together from this database, and this was an interim analysis. And we examined consecutive patients treated with tile-based radiation therapy in the upfront setting after surgical resection of supratentorial or infratentorial brain metastases. One important thing that I think is important to highlight from this data is that the data I'm going to be presenting over the next several slides was not inclusive of patients enrolled into the ROAD study, which has now been a completed randomized clinical trial hosted out of MD Anderson by Thomas Beckham and Jeff Weinberg. In this study, which we will hopefully be seeing finalized data in the near future, was a head-to-head comparison in a randomized fashion between patients receiving tile-based radiation therapy versus standard of care or postoperative radiosurgery following resection of a newly diagnosed brain metastasis. So these cases I'm going to show you here were real-world use cases not enrolled on clinical trial. And our primary outcome from this study was local control and the development of postoperative leptomeningeal disease. In total, we included 51 patients in the study, and these patients were treated between August of 2021 and March of 2024. In total, 55 patients were included in this analysis. The baseline demographics are shown here, but the main take-home from the patients included in this study was that these were patients with large symptomatic brain metastases. Almost 95% of the patients in this paper had one or more neurologic symptom, and the median diameter of these tumors were 3.3 centimeters, which was notably larger than the previous randomized clinical trial published from MD Anderson from 2017, which established postoperative radiosurgery as the standard of care. The majority of patients had a solitary brain metastasis, and median clinical follow-up in this study was 12.4 months. Gross total resections were achieved in the vast majority of patients, but not in all patients, which is also important to note. This is one of the figures from the paper, again summarizing the tile-based radiation therapy delivery shown here. This is the strand with the cesium-131s embedded inside of it. This is a real-world case of tile implantation in a patient. The tile is placed in this specific patient, probably took less than 2 minutes to implant. And this is the patient's postoperative dosimetry showing a fixed uniform dosimetry plan shown here. How did patients do in this analysis? Of the 51 patients included here, over almost 12.5 months of follow-up, the overall local control rate at 1 year post-tile implantation was 92.3%. and the median or the 12-month overall survivorship was 49%. 4 patients developed leptomeningeal disease after brain metastasis excision for an overall incidence in this cohort of 7.8%, and the 12-month LMD freedom rate was 88.5%. As expected for postoperative LMD, the majority of cases were pachymeningeal or nodular LMD, although 1 patient did have classical LMD. Given the low overall rate of leptomeningeal disease development in this cohort, we were not able to identify any one prognostic factor that was associated with LMD development, so this is an area of ongoing investigation. But previous studies have established that breast cancer, infantile brain metastasis, location, piecemeal resection have been risk factors in the past. In terms of adverse events over this prospective study, we found that the overall incidence of wound infection, postoperative neurologic deficits, or cerebral edema were overall low and really pretty much on brand for what one would expect for the normal postoperative natural history for these patients. There was no instance of symptomatic radiation necrosis observed over the follow-up study in this cohort. So, in summary, the major takeaways from this analysis was this was one of the first papers analyzing long-term local control data in a prospective manner for patients being treated with tile-based radiation therapy for newly diagnosed large symptomatic brain metastasis. And overall, there was excellent local control rate in this study, 92.3% at 1 year post-tile implantation. Overall, the incidence of leptomeningeal disease was very modest, with an excellent 12-month LMD freedom rate of 88.5%. And the adverse radiation and the adverse events in this study were not higher than what has been historically reported for this patient population. Just to put this data into context, our 12-month local control rate in this study was 92.3%. The data out of MD Anderson from 2017 demonstrated a local control rate at one year after surgery of 72%. So our data are favorable compared to this data here. Of note, our LMD rates in this study were only 7.8% overall versus 16 to 28% in previously reported prospective randomized data. Other authors have investigated what truly is the overall postoperative LMD risk profile. So this paper here, published several years ago in Neuro-Oncology Advances, pooled 13 studies with over 2,000 patients. And overall, the risk of leptomeningeal disease after brain metastasis resection was found to be 16.1% on average in the literature. Again, our data here are favorable compared to this. When we look at potentially other emerging treatment strategies for brain metastasis in 2026, some centers are actively investigating the use of preoperative radiosurgery. This meta-analysis performed by Jason Sheehan from the University of Virginia pooled multiple studies and examined the outcomes of 616 patients. And what we found was that their local control rates with preoperative SRS ranged quite heavily at the 1 year postoperative mark, anywhere between 77% and 93%. There's been very consistent high-quality local control rates with tile-based radiation therapy, and our data here are favorable to many of the studies reported in this meta-analysis. Other centers have actively looked at intraoperative radiation therapy. Cristoforelli published this study in the Journal of Neuro-Oncology in 2019. This was a prospectively treated cohort of 54 patients. Local control rates 12 months post-IORT were 88%, with an overall LMD rate of 3%. And so what we can see is that tile-based radiation therapy or immediate radiation delivery does appear to be associated with improved local control rates. And in fact, our data seems to be favorable compared to many of these other studies that I've shown here. Well, what about a real-world case? This was a patient who came to see me last year, and she came into the hospital. She was transferred from an outside institution. She was 72, newly diagnosed metastatic non-small cell lung cancer. She presented with progressive right lower extremity truncal ataxia. And of course, she didn't come to our center initially. She was transferred from a community center several hours away from Pittsburgh. And by the time she came to see us, even though she was pretty fit and well at baseline, by the time she got to our institution, she was hospitalized for several days. And as a result of her progressive symptoms, she was becoming more and more deconditioned. Furthermore, in conversations with the patient and her family, it became evidently clear that it was going to be a notable barrier for her to come back to receive postoperative radiosurgery at our institution. So ultimately, we elected to treat her with tile-based radiation therapy. I took out her brain metastasis, treated her with tile-based radiation therapy. This is the dosimetry plan shown here, and at least at the 6-month follow-up, she was doing quite well. And of course, as I predicted, during this time frame, she had multiple admissions to multiple other community-based hospitals within the first couple of months after surgery. These were for non-neurosurgical related complications, and I do think she would have been someone who would have been at high risk for not receiving any adjuvant treatment. So what can we say at this point? These data, which we'll be interpreting in the context of randomized clinical trial data shortly, show very encouraging data on local control, safety, and favorable LMD rates for newly diagnosed brain metastases. Myself and many others are excited and looking forward to reviewing the finalized ROSE trial data in the upcoming year. And overall, our data show that the local control rates do appear superior compared to many other papers that have published outcomes in terms of historical data for postoperative radiosurgery, as well as preoperative radiosurgery and intraoperative radiotherapy as well. So I think in 2026, I think these data really do convincingly demonstrate that there is a role for tile-based radiation therapy or brachytherapy for newly diagnosed brain metastasis. More data is always coming out, and I'm looking forward to reviewing that. And with that, Ashley and Natalie, let me turn it back to you, and let's talk about this.
Thank you, Dr. Shepard. That is really compelling data, and it's exciting because a lot of the questions that we get about GammaTile are related to the risk profile. It makes sense that starting radiation immediately and at the place where the disease burden is the lowest is going to result in better local control. But because of the history of brachytherapy, we often get the question, well, is that safe? Is that benefit worth the potential risks? And this paper really shows that the harms rate is low, or at least comparable to the existing standard of care. And then showing on top of that the local control rates appear to be even superior is really exciting.
Yeah, no, absolutely. I think anytime, look, as physicians and neurosurgeons, radiation oncologists, one universal thing in life is that no one really likes change. We all kind of figure out, hey, what we like to do, what we were trained to do, and this is different. And I can understand the hesitation at first when you've first considered treating these patients in a different way. I think when you have done cases and you see favorable outcomes for folks who may never have received radiation therapy at all, I think you start to become a little bit of a believer in that. And I'm certainly not a radiation physicist or a radiation oncologist, and so I don't mean to speak out of my wheelhouse, but when you look at the dosimetry fall off in these patients, we're really looking at tight, dosimetry plans here. So if you're putting a tile in a resection cavity, the dose is maybe 5 millimeters, or you're really seeing the potential for any appreciable dosing to the surrounding structures. And the scalp, the incision, that's greater than 5 millimeters away. You put the bone flap on, you put the Geiger counter there, you're really not seeing any appreciable radiation dose to the scalp. And so that's why I don't think we're seeing significant rates of wound dehiscence or appreciable rates of other wound healing complications or radiation necrosis for that matter.
Yeah, I'll just add, I mean, the safety profile in this paper I think was really compelling, right? And you kind of hit on this. It was super low toxicity, no cases of radiation necrosis. I would say just in general with that in mind, what stood out most to you, or were you surprised by anything that you found in the safety observation in the publication?
I think when you look at this, was I surprised? I mean, I think it's a little bit, you expect to see maybe some toxicity, right? But you're not seeing that. And I think, one could be pessimistic and say, well, are they really capturing how they're defining it? But this is prospective data. This is not me doing a chart review with my residents and fellows and students. This is real-time data that is being submitted, and we're just not seeing that. In fact, I mean, the adverse events in this study were very minimal. Now, granted, there's a lot of really high-level centers who are doing great surgeries in this, and so obviously I think that has some reflection on the the early adopters being centers of high volume and good case utilization. But I'm not, at this stage I'm less surprised. I think I would have been more surprised maybe 4 years ago when I first started thinking about this technology. But even in the heavily re-irradiated population, we're not seeing adverse radiation events that are higher than historical controls with repeat radiosurgery, for example. So with that in the context, I am surprised, but I'm also now really not.
Yeah, I think the point that you made earlier on too, with this being from the registry, this is real world patient data, right? This isn't from a controlled trial. This is, and I think it's just compelling. I love that the data has just been so consistent, right? We're consistently showing high rates of local control without adding anything to the risk profile. And this paper did a great job of highlighting, I think, just that.
Yeah.
One thing I really enjoyed the discussion portion of the paper, and you guys discussed a lot of just some around timing of when radiation delivery is achieved. And I would love to just kind of hear you expand a little bit on that, even kind of thinking through from a logistical standpoint, because I think you guys did hit on that quite a bit in the paper too. Just logistically, in your opinion, why is kind of immediate post-surgical period, like why is that so important with regards to the delivery of radiation?
Yeah, yeah, thank you. That's a good question, Allie. And I think Ashley, you mentioned some of these topics maybe earlier. What we're doing, the way we've been doing things in terms of adjuvant radiation therapy until more recently is we are essentially allowing the tumor to grow back potentially before treating it with adjuvant treatment. And why are we giving these tumors the benefit of the doubt? Why are we allowing them to grow back before we treat them? It doesn't make sense from a cancer standpoint. It doesn't make sense from a radiobiology delivery standpoint. And we know that the number of cells that you need to even be visible as a speck on an MRI is something astronomical. And so just because you're not seeing it, it doesn't necessarily mean that those cancer cells are not even there by the time you're treating a lot of these patients with adjuvant radiosurgery. So I think when you get to the point where you have maximal cytoreduction, it certainly makes more sense. And I think, again, part of this too is, hey, look, there's a substantial proportion of patients who are simply not going to come back to receive post-operative adjuvant radiation treatment. And it's not because of any fault of their own. It's not because we're not referring these patients. It's because there are only so many tertiary centers in the state of Pennsylvania, and if you live 2 hours away from where I practice, you're in a very rural community, and the access to care is a real issue. And I think what we need to think about at this in some ways, that this is a healthcare equity issue in some respects. Why does a patient who lives in Warren, Pennsylvania, which doesn't look far away on the map, but because the way that they designed the roads in Pennsylvania, it takes them almost 4 hours to get here, why should some person not be able to receive timely radiation therapy, but yet someone who lives in Squirrel Hill or Shadyside is going to be able to have a better chance of access of care? We're just guaranteeing treatment with this, and I think it's probably just the right thing to do, with these data. And again, we've all seen the preliminary roads data, which is very promising. And I can understand people saying, "Hey, look, let's wait for the final randomized data." I think that's totally fine. But if the prelim data with the Rose clinical trial data, which was presented at the Congress of Neurological Surgeons last fall, bears out, I think this is going to be a very hard argument. We're going to have a hard time justifying why you don't want to change.
Love hearing that. Absolutely. And you guys discussed it in the paper too. And it's like, it makes perfect sense for patients that do live far away, right? They might not come back, but even, I mean, there's been publications that will show that even if a patient doesn't live far away for whatever reason, potentially a third of them might not come back at all for treatment. So to your point, why not give them the opportunity to receive the treatment
Yeah,
immediately right away, right? Like you said, the right thing to do. One thing you also mentioned was, and you kind of said this too, like you guys had a really high rate of gross total resection. In your opinion, how does achieving a gross total resection influence cavity management and also kind of the role of the immediate delivery for these patients?
yeah, I brought that up that, in some ways, I mean, it definitely was a very high rate of gross total resection, over 90%. But one key point is when you examine the MD Anderson data from 2017, every patient who was randomized to postoperative radiosurgery, it was mandated that you had a gross total resection. So what we're seeing here is that there's local control rates as high, over 92%, when in fact some of those patients had stable disease when they still had residual tumor left behind. So that's an important distinction. Now, of course, we're all achieving for gross total resection, but not at the expense of neurologic loss of function. And certainly sometimes tumors can be in difficult areas to resect, and you have to make that intraoperative decision about whether or not the risk profile is worth it or not. Certainly, if you have residual disease, those patients are going to need to be treated ideally sooner rather than later. And tile-based radiation therapy would allow for that. Those are patients who we know, I think, are at higher risk of having more rapid early regrowth of their tumors if there's gross residual disease left behind.
I like that you hit on that earlier, where it's like there's potential for active, cells to be there. So why not put that in to make sure that you're kind of,
Yeah.
Covering all your bases, if you will, right? So I have one last question for you. Love that the paper kind of reported that strong local control, encouraging rates of LMD, as you guys had stated. In your opinion, how do you think that clinicians should take this information and interpret these findings in their own real world practice? And how do you think that this fits within kind of that broader evidence for managing patients in this, newly diagnosed brain met setting?
Yeah, what I think this paper does is, this is not randomized clinical trial data. So I think if there's really people who are on the fence about, hey, is this the right thing to do or not? Is this the paper that's going to push you over the edge? Maybe, maybe not. What I would hope that people take away from this is that tile-based radiation therapy or brachytherapy is safe for receiving a high degree of local control rates. I don't think it's weird anymore. I think there was a period of time where some of people who were doing more of this, we were all kind of like just out there on our own. We didn't know, is this a thing? And I think this data validates that, hey, look, this is a really established treatment for these patients. Number one. Number two is I would implore folks to consider continue to make the right call for the patient in front of you, right? So this data is not telling you, hey, you have to use tiles in every single patient, right? There's some patients, however, I would challenge you to say, hey, look, if you think you have someone out there who is really at high risk for not coming back to receiving postoperative SRS, then maybe you should consider tiles. And I think that would be the main take home. Again, and I think in the next year, we're going to see other randomized clinical trial data that may push others. We're definitely going to probably reestablish this standard of care. And I think this data is really just more of a prelude to what's to come.
That's great. Thank you so much. Yeah, like I was saying earlier, I think what's been great is all the data that we've seen so far around GammaTile, it just continues to be consistent, continuing to show those high rates of local control and really, really great and stable safety profiles. So with that, I would say if there's anything else that you kind of wanted to share with the audience or any last thoughts.
No, I think this has been a great conversation. I think we've hit the highlights so far. So I would encourage, if there's anyone out there who has any questions along the way, I think my contact information is in this paper, so feel free to reach out to me. But this was fun, Ashley and Natalie. Hopefully we can do this in the future.
Absolutely. Thank you. This was a great discussion. Thank you, Natalie and Dr. Shepard. Thank you so much. This paper really is just another proof point, right? That GammaTile is a useful tool in a neurosurgeon's armamentarium. Again, not for every patient, but for a selection of patients, this could make a huge difference in outcomes. So thank you so much for sharing.
Yeah,
Yeah,
thank you, Dr.
absolutely.
Shepard.
Thanks for having me here.